Hello everyone, welcome back. Today I'll be covering back pain in adult, the differential diagnosis, a part 2 video. I will be discussing the common differential diagnosis discussion summary. These include 1. Herniated disc, 2. Degenerative spinal stenosis. Now let's get started. As an introduction, tests in the annulus fibrosus from trauma, degenerative changes, or a combination of both can cause a portion of the gelatinous nucleus pulposus to extrude through the defect of the surrounding annular fibrocartilage. The resultant mechanical pressure exerted on the nerve root and the thicker sac, as well as the chemical irritation from direct contact between the nucleus and the nerve, leads to signs and symptoms associated with lumbar radiculopathy. Clinical manifestation. Patient may complain of lower back pain and leg pain. It may be associated with numbness and tingling in the affected lower extremity. The pain may start in the lower back but then travels down to the posterior aspect of the buttocks and thigh into the leg and the foot. The pain is worse with sitting and is relieved to some degree with standing or lying in certain position. Patient may experience pain and paresthesia with increasing frequency and duration over days or months. Patient may recall a specific traumatic event that brought the symptoms, or patient may inform that the symptoms have gradually progressed over time without a specific inciting event. The pain described as stabbing in nature, that start in their lower back and radiates to the affected buttock around the L4, 5 and S1 nerve root. This figure shows the L4, 5 S1 myotome examination. You can see the L4 is at the medial side of the calf region and the medial side of the foot. For L5, lateral aspect of the calf region, and S2 is at the posterior calf region. For S1 is lateral aspect of the lateral side of the foot. Anatomically, the most common sites for a herniated nucleus pulposus occur at the L5-S1, L4-L5, and L3-4 intervertebral discs. The disc herniates posterolaterally in the direction of least resistance, just lateral to the posterior longitudinal ligament. The disc material most commonly causes compression of the transversing nerve roots, although with the more superior migration of the herniated disc, the existing nerve root can be affected. This picture illustrates the difference between disc protrusion and disc prolapse. For disc protrusion, the disc protrude and compress the nerve root. For disc prolapse, there will be a torn annulus fibrosus whereby the prolapsed disc will impinge on the nerve root, causing compression. While the most clinical presentation involve one leg or the other, a large disc can cause symptoms on both sides of the body. Cauda equina syndrome, a rare presentation of this herniation, may result from a very large compressive lesion that can also affect the bowel and bladder function by compressing the entire thicker sac and affecting the S2 to S4 nerve root bilaterally. This figure illustrates the central disc herniation. It shows the central protrusion of the disc into the spinal canal. For physical examination, patient usually request to remain standing or sitting for a short period of time. It is usually very uncomfortable. They often try to find a comfortable position to reduce the amount of pain and paresthesia in the affected extremity. There may be decreased lumbar spine range of movement due to pain. Near normal neurologic examination with full motor strength in both lower extremities. Occasionally, patients have weakness in the affected lower limb extremity muscles innervated by the affected nerve. Patients typically experience the difference in sensation between the affected and the non-affected side, saying that the leg feels like falling asleep. Sensation to light touch is typically preserved. Reflexes on the affected side may be blunted and less brisk than the unaffected contralateral side. Provocative tests include SLR, straight leg raising test is positive. A positive contralateral SLR is considered an even stronger prognostic indicator of herniated disc. For this herniation at L2 to L3, a femoral stretch test can elicit the same pain and numbness that patients normally experience. In the first video, I already discussed regarding the slate raising test and the positive contralateral SLR. This figure shows the femoral stretch test. Patient will be in prone position. The examiner will pull upward the extended knee or push it upwards to passively extend the hip. Pain is a positive sign. In patients for whom caudal equina syndrome is a concern, perineal and perianal sensation should be documented. The patient should be asked to distinguish between the light touch and pinprick. Please assess the anatome for its laxity. This picture illustrates the pinprick sensory anal sensation test. There will be an impairment or it's positive if there is pain reduced or no perianal sensation present during the examination. Laboratory study and radiological investigation. The diagnostic study of choice to assess the herniated disc of the lumbar spine is a magnetic resonance imaging MRI scan without contrast. MRI scanning is 98% sensitive and specific for the presence of a herniated disc and will provide the information about the location and size of the herniation as well as the affected nerve root. It can also differentiate a sequestered disc, a free fragment, from an extruded herniation that still continues with the ruptured disc and a protruded disc that has an intact annulus fibrosus. In patients with a pacemaker or aneurysm clips that are incompatible with MRI, a computed tomography myelogram is the best choice. Although it does not provide an accurate detail of surrounding soft tissue, the absence of contrast material overlying the suspected region of involvement does help to provide an accurate representation of the location of a herniated disc and the nerve root affected. plain X-ray are not helpful in determining pathoanatomy, helpful in verifying the appropriate operative levels. This radiological ambulosacral X-ray shows a normal characteristic of the spine during AP and lateral view. Treatment. Most patients with herniated disc may be treated with good success non-operatively with physical therapy, medication, injection, and activity modification for a short or intermediate time course. Physical therapy include core strengthening, stretching, and range of movement exercises. Modalities example transcutaneous electrical nerve stimulation, TENS, deep tissue massage, and manipulation may be done with varying degree of success. Medication example NSAIDs, non-steroidal anti-inflammatory drugs, helps reduce the chemical irritation surrounding the affected nerve root. Important point in treatment. Non-operative management of lumbar disc herniation is successful in most cases. Transforaminal injection are a treatment option when physical therapy and medication do not provide sufficient relief. Surgical treatment typically involve hemilaminectomy or laminectomy and discectomy. So, when to refer? Failure to respond to non-operative management, progressive neurological deficit, sign and symptom of cauda equina syndrome. Please take note. Number 2, regarding degenerative lumbar spinal stenosis. The clinical presentation. Degenerative lumbar stenosis is characterized by back and leg pain caused by narrowing or stenosis of the spinal canal. The narrowing, usually a degenerative condition produced by a combination of protrusion of the intervertebral disc and hypertrophy of the ligamentum flavum and articular facets, leads to compression of the neural elements with resultant buttock and radiating leg pain. Symptoms of degenerative spinal stenosis typically does not manifest before the 5th or 6th decade. Lumbar spinal stenosis can also be developmental, idiopathic, or a consequence of metabolic bone diseases such as osteopetrosis or achondroplasia. Lumbar stenosis is often progressive with gradually increasing compression of the thecal sac, nerve roots, and rarely cauda equina. Lumbar stenosis is thought to start with a subtle instability between the vertebrae. In an effort to provide additional stability, there is subsequent hypertrophy of the ligamentum flavum and articular facets. Unfortunately, this compensatory process crowds the neural structures, causing both mechanical compression and chemical irritation to the nerve. Postural changes may have significant effect on pain intensity. Standing and walking tend to exacerbate the pain, whereas sitting provides gradual relief. Patients claim that pushing a shopping cart is the pain because the forward flexion allows the lumbar spinal canal and foramina to open. This is referred to as neurogenic claudication. In older age, need to differentiate between neurogenic versus vascular claudication due due to the treatment options differs for each condition. This is a very important table, the difference between or comparison of neurogenic and vascular claudication. For spinal stenosis, patient will have a neurogenic claudication. Patient complain of leg pain but often started from proximal, buttock and the hip. It might be an intermittent pain. Patient relieve the pain by hunching forward, which tends to stretch open the spinal canal and make more room for the neural elements. Clinically normal peripheral pedal pulses are palpable. Confirmatory studies with the MRI of lumbar spine. In vascular insufficiency, classic claudication, patient complain of leg pain, but the pain usually starts from distal at the calf region especially and upwards. Because this is caused by muscular ischemia, pain uniformly and invariably increase with increasing activity. Patient obtain relief with stress. This will abate with rest and reperfusion since the underlying problem is muscular ischemia. Clinically, signs of vascular insufficiency, but it can be normal too. Please be aware of occult vascular disease. There would be sometimes non-palpable pedal pulses, presence of hair loss of the skin. We can confirm it by using a vascular studies. Clinical examination. Patient may walk with a flat spine using a cane or walker to help support that posture. Patient may be able to reproduce the pain in the clinic by extending the lumbar spine and holding that position for several moments. Usually, the lumbar stenosis patient have normal physical examination findings. They may have some decline in two-point discrimination in the lower extremities, but sensation to light touch is usually well preserved. Studies using lab investigation or radiological investigation. Common radiological findings of spinal stenosis include vertebral osteophytes, end plate sclerosis, disc space narrowing, facet hypertrophy, and loss of lumbar lordosis. X-ray helps in rule out other sources of back pain such as compression fractures, spondylolisthesis, or tumors. MRI, magnetic resonance imaging, is the best diagnostic study to assess lumbar stenosis. Ligamentum flavum hypertrophy, facet hypertrophy, and disc bulge that contribute to thicker side compression and central stenosis can be seen on MRI. This lateral radiological lumbar X-ray shows a narrowing of the spinal canal due to stenosis caused by posterior osteophyte and shortening of the pedicle. Treatment for lumbar spinal stenosis patient. Best first management, non-operative treatment with physiotherapy and analgesic. In physical therapy, patient focus on flexibility and strengthening of the spine and abdominal muscle. NSAIDs, non-steroidal anti-inflammatory drugs, and muscle relaxant can be effective for radicular pain and paresthesia. Neuromodulators, example gabapentin and pregabalin, can also be used. Tricyclic antidepressant may be helpful in patients with chronic and neurogenic pain. Surgical treatment for spinal stenosis centers on decompression. Favorable results from surgical decompression are more likely if the chief complaint is buttock and leg pain but not back pain. So when to refer? Failed non-operative management of symptoms, progressive neurologic deficit, cauda equina syndrome, emergent referral please, the suspect of spinal infection or malignancy. Yay, we have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.